I first met Dr. Lane Schnell in the emergency room at Christus when it was still Trinity Mother Francis. I was a chaplain there, and I saw the way he moved around stealthily. He's not a guy that makes a big footprint, makes a big splash, but he makes people feel heard and seen. And if an emergency room doctor can do that, they're going above and beyond the call of duty. Because they have so much going on, they have so many things to do, they have such a full plate. And so as I observed all the doctors, as I did, I observed Dr. Schnell just being a guy of class and dignity and treated everybody as such. And it's no surprise that he's risen to leadership every place he's been. He currently is the medical director for what they call the emergency department now, right? The ED, no laughs, at UT Athens. Is that correct? Mm-hmm. Okay, boss, the floor is yours.
All right. Everybody hear me okay? Yes. All right. I see some familiar faces, so that's nice. Thanks for coming, and it's always fun to talk about the emergency room and what happens there. And thank you for the introduction. Recently, I also took a role in overseeing all 10 of the ERs for the UT health system. So that keeps me busy, and I still work clinically as well, full time. But really, that's kind of the key, because actually that's UT calling me right now, but I'm going to put it on hold. But working clinically and being in the ED every day, or nearly every day, is really what helps me understand what the issues are and what the problems are and how to fix them and make them better. And but I was asked to talk a little bit about the emergency department and how we approach mental health and substance use disorder as well. And so we'll jump in and do that. Now I guess the computer's here, right? So there we go. So just a little fact, data doesn't get produced as quick as we'd like it, but between 2007 and 2016, almost 10% of the emergency department visits nationwide were for psychiatric or substance use related diagnoses. So that was in the diagnosis at the end of the note that the physician or the provider wrote down. It was related to a psychiatric illness or substance use. So that's a pretty big number. And I would venture to say that it's even higher than that, because that's just what ends up in the diagnosis. And sometimes it's still a component of what's going on, but it doesn't end up as an official diagnosis. And then this is a graph, and the main point on this is to look and see who patients are covered by. And you can see that the blue is Medicare, so this is mental health and substance use disorder. You can see that the Medicare, actually in what year was that, 2015, seemed to drop quite a bit. But if you look at the blue and the red together, you can see that a bulk of the patients that are seen in the healthcare system are covered by Medicare and Medicaid. And I think a lot of you in the room probably are much aware of the problem that presents, because Medicaid and Medicare aren't the easiest systems to navigate, and maybe not the best benefits either. And so we're very limited. And then you can see there's actually a big chunk too that have none, and so the challenge is pretty big. All right, so we'll kind of walk through the emergency room about how visit happens, how it takes place. And some folks come by ambulance, some come by private car, some are just walking by on the street and say, hey, I'm going to go check in. So we got this guy here, and he was cleaning his bow and arrow, and it went off, and he got injured. But the emergency department sees everything. That's why I put this up there. And For some folks, it's a surprise that we see mental health patients in the ER. They don't necessarily think about that, but a large part of what we do is mental health related. So you check in, and then the whole process starts. And so you get triaged, and you get your vital signs taken, and I have a slide later on in the presentation that goes through all this. And part of the triage process is to figure out how sick is this person, what resources do they need, and how quickly do we need to get them in front of a provider. But what I thought we'd do is I have about 15 cases, some are longer, some are shorter, just to talk through. And these are patients that have been seen in the emergency department, and their visit reason is across the whole gamut, but related to mental health and substance use. So the first one, a 56-year-old homeless male hearing voices telling him to harm himself. So when I came on shift, I saw this patient, and he was homeless. You might be interested to know what the temperature was outside. We were having a really cold spell, so it was below freezing, or about freezing. And he brought in his window washing bucket because he would walk the streets of Tyler and try to get a job of washing windows. And that was a source of income for him. But it's really cold right now. He doesn't have a place to go. I mean, you don't know if exactly that's why he checked in, but I think a lot of people thought it, like, well, here's someone who's homeless and doesn't have anywhere to go. It's really cold outside, and he probably would like a warm place to be. But he says he was hearing voices, and these voices were telling him to harm himself. He did have a history of mental health disorder. So you walk in the room, and that's what you're presented with. And so I bring this case up because part of the challenge in emergency medicine is to sort through who really needs the resources and who doesn't. And it's the same for all mental health patients. In your roles as well, you're trying to sort through what resources are needed. And we do the same in the emergency department. And so I'm trying to figure out, is this just a normal day for him in hearing the voices? Is this, or is he just really cold and he needed a warm place and some food? Or is it both of those things? A mixture of the two. And so that's our challenge. That's our challenge in the emergency department. He ended up being with us for a couple of days, and I'm trying to remember, because during that cold spell, he actually came in a few times, and a couple of times says, yeah, I think I'm ready to go now, and he'd go, then he'd check back in. And I believe one of the times we did end up getting him placed. And the other thing is you have to, I always give the patients the benefit of the doubt, and you try to be as objective as possible and have some objective data. But at the end of the day, if you have someone who's saying, hey, I don't feel good, I'm hearing voices, the voices are telling me to harm myself, then we go with that, and we try to get them some help. So that case just highlights a certain population that we do see. Okay, the next one. This was probably the youngest patient I've seen with a mental health problem. It was a 5-year-old that was sent from the school with suicidal thoughts. So has anybody seen a younger age? I can imagine maybe a 4-year-old, but when I saw this, I was like, wow, a 5-year-old? And because in some of my thoughts are that I don't even know if the teenage population fully understands, the difference between life and death and making those types of decisions. And so here you have a 5-year-old. So obviously they've been exposed to something where they kind of know what suicide is, or they know what it means to make a threat of hurting or harming yourself, taking your life. And so the school sent them over. Part of the reason I include this situation is, in this case, is because right now in Tyler, I have no inpatient facility to send any pediatric patients to. And so when a family shows up with their child, 18 or below, 18-year-old I can get in, usually get into an adult facility, but below the age of 18, I tell them up front, I said, we're going to do everything possible, but I don't have means to do an inpatient admission in the Tyler area. We either have to go to Dallas or the Metroplex there, or to Shreveport. And most of the time when I mention that to the family, they're discouraged because they want help, but that's not practical. If you have a loved one being hospitalized, how practical is it that it's 2 hours away, you know, that it's 90 or 100 miles away? And that brings a whole nother element to the process and to the problem. So in your roles and in what you do on a daily basis, if you can advocate for behavioral health services for pediatric patients in the Tyler area, you know, Smith County area, please do advocate for that. And I will say that UT has a residency program to train psychiatrists, and then a fellowship for child and adolescent psychiatry. And so hopefully with time that passes, we will be able to augment our services to this population and be able to help them out as well, and maybe even have inpatient services that are available. So this patient, we talked through things, and we just came up with a good plan. The parents felt comfortable taking their daughter home, and then just seeking some outpatient counseling and assistance. We didn't go inpatient on this one. All right, a 23-year-old male brought in by the police after running a red light. So this is a case that I saw in Athens when I was there. And so a lot of times we will have patients come to us who are in custody of law enforcement, and they ask us to do a medical clearance exam, and they're basically saying, is this person safe to be incarcerated? And so we're just getting a snapshot in time of looking at these patients when they come in. So this 23-year-old was, he ran a red light, and then so the police started following him and to pull him over, and there was a little bit of a chase through the Athens area, and they finally caught up with him, and they brought him in. They wanted to, you know, they had arrested him, and they wanted to take him to jail. And he had possession of methamphetamines at the time. So when I went and do my exam, he of course, you know, physicians, we asked the patient, what's going on, you know, how do you feel, and you know, what's their chief complaint, and he didn't even want to talk. And I can't blame him, because the police are standing there, and he just got caught, and I don't think he had much to say. So he was just pretty quiet. When we did his vital signs, his heart rate was over 100. It was like 113, 115 with him just sitting there at rest. And a resting heart rate should be, you know, 60 to 100 is technically normal, but it's probably going to be 60 to 80, especially in a young, healthy patient. So everything else on the exam seemed fine. He was just a little bit agitated, and he would, you know, follow commands. He'd answer simple questions, but his heart rate was fast. And so I thought, well, one thing that you learn in medicine and go through medical school is if a patient ever has an abnormal vital sign, you have to address that. You have to have a reason of why it's abnormal, and then address it before you can just dismiss that patient and discharge them. So I didn't have a reason why, and so the law enforcement, they were thinking a little upset with me, because I went and I said, hey, I can't medically clear him because his heart rate's too fast. And I said, I can start a workup and look into seeing why his heart rate's so fast, but I can't just, by examining him, say he's clear and it's okay to take him to jail. And so they said, okay. So I started the evaluation. It wasn't, and put in some orders in the computer, and probably 3 or 4 minutes later, not much time had passed, they asked me to please go in the room and see him again. The nurses did. And I did, and he was becoming more and more altered. So I suspected that he had just recently used some of the substances that he had on him before the police had gotten to him. So I had the orders in. I asked them to move him to a room with a monitor, and he quickly decompensated and he started to seize. And so I had to protect his airway. He had to be intubated and put on a ventilator. And we did that, but he kept seizing. I had to sedate him on high doses of benzodiazepines, which will all the excitatory stimulation from methamphetamines can cause seizures in a hyper-excitable state. And so we were trying to suppress all this. And anyway, so in so doing, he gets worked up and he gets admitted to the intensive care unit. And he stays on that ventilator over the course of the night. The next day they were able to wean that and take him off the ventilator. I later found out that this wasn't the first time this had happened. He had actually been intubated and on a ventilator before because of an overdose. Now this particular overdose was very dangerous because what he actually did was, before he was apprehended by the police, he wanted to get rid of any evidence that was there, and so he quickly swallowed and took. He had all the methamphetamine in a plastic bag, and he ingested that. Well, there's body packers and body stuffers. All right, and I don't know if you've heard those terms. One of them, body packers are very professional in what they do. They package the drug that they're trying to conceal in very thick wax capsules, and they ingest those, and they can ingest about a kilogram worth of weight of the drug, and cross borders and whatnot, and travel with that inside of them. But there's a very small chance of a leak or that those break open when they're doing it, but body stuffers are just quickly trying to stuff it in their body to get rid of the evidence, but it's usually it's not packaged correctly, and so these bags will break open. So he had a huge dose of methamphetamine that actually would have taken his life. And so in this situation, I don't think that law enforcement would have gotten very far from our hospital, but had I have disregarded his high heart rate and said, yeah, you can take him to jail, he would have quickly decompensated and been right back into the ER, but maybe even not to us quick enough to do something about. So anyway, so he... this is another population, another thing that that we're approached with and that we see. All right, 26-year-old female presents for a rash. This is a pretty quick case to talk about, but sometimes someone will check in and they say, I'm just here for a rash. But then you go in the room and you quickly see that, well, this person feels like they have worms crawling all over their body and that they're picking bugs out of their skin. So what drug is she probably taking? Yeah, exactly. So you've seen this, and so when you look at chief complaints before you go to see a patient, it's not always what you think it is. You could be walking in there thinking, oh, this is going to be a really quick visit, it's for a rash, but you get in there and it's a mental health issue and a substance use disorder. So. All right, a 15-year-old female who overdosed on Benadryl, and she truly had an intent to harm herself. So when she came in through triage, because her family brought her, they found her and she was, so when you take Benadryl, it makes you tired, right? So she was kind of somnolent, a little bit lethargic, not answering questions, very sleepy, and her family brought her to the emergency department, and by the time they got to the hospital, she was so out of it, they had to carry her in. And then she very quickly started to seize because she had taken so much. So I tell this story, bring this one up because of how difficult it was to treat. So when we discovered pretty quickly that it was Benadryl that she had taken, there's an antidote for that, and it's called physostigmine. And if you give physostigmine, it's the antidote, so it gets rid of all symptoms of the Benadryl overdose. And sometimes you have to redose it a few times, but it helps you get through the overdose without any of the untoward effects. Well, there's a national shortage of physostigmine and no one has it. And so then we had to think outside the box. So we're like, okay, well, when I trained, anybody who had a Benadryl overdose, we gave physostigmine. But so then we had to go to the second line treatment, and that is usually benzodiazepines like lorazepam, Ativan, Valium, Versed, those kind of drugs. And so that's all we could give her. I had to put her on an Ativan drip, lorazepam drip, because the overdose of the Benadryl was causing seizures, and so I just treat the seizure. So she also had to be intubated and put on a ventilator, and then put her on an Ativan drip, which would control the seizures, but it wouldn't reverse the other effects of the Benadryl overdose. So I had to put her on a bicarb drip too. So she was getting sodium bicarb through a drip. And then of course, being 15 years old, we don't have a pediatric intensive care unit in Tyler. So we flew her to Dallas, to Children's Hospital. The family, of course, was very beside themselves. She had never done anything like this before. The family had heard her say a couple of times that, that she was sad or depressed. And the danger of this is, it wasn't a huge amount, but it was, of course, a critical amount to cause these symptoms. And it was potentially very harmful to her. She ended up having a full recovery and doing fine. But I wanted to talk about this case because of some of the factors that we deal with where we don't have the antidote because of a national shortage. And especially in a post-COVID world, we deal with that quite a bit, where medications that we need are not available. All right, so 18-year-old female with multiple cuts on the arm. So several of you have probably seen patients who we call them cutters, and they cut. And when you go in and examine them, you look at the cuts, or maybe they don't even tell you that they cut, but part of your exam is you need to look at places like that, look at their skin, look at their legs to see if you see cutting. Most of the time, they're very superficial, and it wasn't necessarily done with an intent to take their life, but maybe with an intent to harm themselves or to inflict pain that will take their mind off something else that's bothering them. And so you have to sort through those things. This particular patient they were just all superficial, and none of them needed to be sutured back together or closed. And they could just, put some antibiotic ointment on and a dressing, and then go about the medical clearance for a mental health patient who is having thoughts and actions of self-harm. I have had patients, though, who have been labeled as cutters before, and they continue to cut, and they get deeper and deeper, and actually have cut into an artery in their wrist, and it needs to be ligated and sewn shut so they don't continue to bleed. So it's a whole spectrum, and you do have to be cautious of that. But I would say most of the time, in this population, they're just very superficial cuts, but yet it's a clue that helps us hone in on things that could be bothering them. I've had patients come in for other reasons. Maybe they're there for nausea, vomiting, or they had a fever or whatever. But on the exam, we'll happen to see some cuts, and so you see these patterns, and then it's brought up the opportunity to ask the patient, hey, did you do this to yourself, and why, and how can we help? So just something to watch for. All right, 42-year-old male with suicidal ideation and drinking alcohol. So this could be a plethora of patients. How many patients do we see who come in intoxicated, especially with alcohol, and they're saying they're suicidal, but they're intoxicated? And so what we have to do in these situations, you don't get a very good history in physical exam when you're talking to someone who's intoxicated. And some of them are, you know, if they're, you can get an okay history, but most of the time you can't. And so we pretty much just kind of sit on these patients and wait for their blood alcohol level to come down. In general, it comes down about 30 points an hour. And so you can get initial alcohol level and then calculate out how long you think it'll take for them to have a legal alcohol limit. And then at that point, we're able to have a more meaningful exam. And then when we call our local mental health authority, which is the Andrews Center here in Smith County, we can say, hey, yeah, their alcohol levels, you know, below the legal limit. And sometimes the alcohol level gets down that low and the patient says, hey, I'm not suicidal. I was drinking and I don't want to be here. And we can't hold them. We can, of course, try to offer services and see what how we can help. But if they want to go, then they go. And some become sober or they get their alcohol level down into the legal limit and they still are suicidal. So I bring this case up just to point out this class of patients and that come in intoxicated, and then we have to wait a little while before we can actually do our exam and understand if they truly need services or not. Any questions so far? If anybody has a question, raise your hand or ask your question. All right, a 54-year-old female with anxiety, just getting over COVID. So this was a couple years ago during the height of COVID. She was feeling depressed, and her primary doctor started her on an SSRI, which is a serotonin selective reuptake inhibitor. So like sertraline or Zoloft, Celexa, kind of that class of medication. So she was started on one of those, and she started getting so she couldn't sleep. She was agitated. She was having rapid thoughts. And her primary doctor called me and said, hey, I'm sending my patient to the emergency department because she's suicidal. And she was a school teacher in her local community, and he said she's really beside herself, but she's suicidal, and and I don't know what else to do for her. She needs help. I think I would recommend that you pursue an inpatient hospitalization so she could have a psychiatric evaluation. So I went into the room to see her, and her husband was with her, and she was very tearful. But there was a key piece of information in her history when I talked to her, because I asked her, I said, "Are you suicidal?" And she said, "Well," she said, "not really." She said, "But I feel so bad. I feel so anxious. My thoughts are so rapid." She said, "If I continue to be like this and have these symptoms, I'm afraid I'm going to hurt myself because I feel like I'm going out of my mind." Well, that's a little bit different than someone saying, "I don't want to be alive and I want to hurt myself." And as I further talked to her, I found out that she had just gotten over COVID. She was better. She didn't have to be quarantined anymore, but she had just had COVID. So one thing that we noticed during COVID was that COVID had the ability, because of some inflammatory responses, especially in the brain, to cause something that we call serotonin syndrome. And to increase the levels of serotonin in the brain to a point that patients became agitated and had some psychiatric manifestations from COVID. And to top it off, her primary doctor, because she was depressed, had just started her on an SSRI, which also increases serotonin levels in the brain. So she had COVID and the SSRI, which were both playing off of each other, increasing the serotonin levels in her brain. And so when I examined her, there's one of the key features of a physical exam on someone with serotonin syndrome is their neurologic system becomes very excited. And so when you test their reflexes, they're extremely brisk. And there's something called clonus, which is where when you test the reflex, it keeps going and it keeps beating. And you can, when they have a patient laying down, you can go up and you put your hand under their knee and you grab their foot. And if you jerk their foot up like you're coming off the gas pedal, and their foot beats back at you a few times, that's clonus. That's a positive test for clonus. So I did this on her exam, and I was already thinking, hey, she's got serotonin syndrome. And so I did this exam, and sure enough, she had several beats of clonus. And so I knew she had serotonin syndrome. And so I talked to her and her husband. I said, my assessment is that you're not really truly suicidal. I believe you have serotonin syndrome because you just had COVID and you're on a new medication that can precipitate these symptoms. I think all you need is some Ativan or lorazepam, something from that class, maybe a hospitalization, not in a mental hospital, but in a medical hospital for overnight or a couple of days to calm down the hyperexcitability of the brain. And then I think you'll be fine. And she started crying and said, I mean, she was on board for that treatment. And she didn't want to go to a mental health hospital. And I told her, I said, I don't think you belong there. I don't think, some patients need that. But I said, I don't think you need the services of a mental health hospital. So the next step was to call her primary doctor, because he was saying, hey, she's out there, she's going to commit suicide. And I needed to call and convince him that it was okay for her to be admitted to a regular hospital and that she wasn't truly suicidal, and let's treat her with some benzodiazepines at least overnight and see how she does. I gave her a dose in the ER, and it helped quite a bit. And so I called her primary doctor and I said, hey, this is my assessment, this is what I think. And he was on board. He said, yeah, let's admit her here. And he said, I'll take care of her and let's see how it goes. So she got admitted, she stayed overnight, and into the next day, she got several doses of benzodiazepines. She was a whole new person. She got good sleep that night. All of the agitation and the rapid thoughts went away. So of course she wasn't thinking suicide anymore, and she went home. And she didn't have to stay on that medication, but she had some for a short time while things stabilized, and of course then she was taken off of the antidepressant medication because that was precipitating it, and everything got better. So this is a good case that I like to tell about, because someone who came in suicidal but had a medical reason of why they were suicidal, something that's very fixable, and then she was able to be treated and go home. All right, 89-year-old female from a skilled nursing facility says she wants to die. So this is a common presentation, actually, where a nursing home will send a patient and said, hey, they want to die. And I can't say I blame her. You know, she'd lived a long life. She was all alone. She didn't have family. She's in a nursing home, and she's just lonely. And but of course, you know, you have to go down the pathway, and you have to do medical clearance, and the nursing homes, you know, if they've determined that one of their patients is suicidal and there's not a medical reason for it, they won't take them back until we do, you know, treatment and we figure it all out. So sometimes we still have to send them to a behavioral health hospital and get an official assessment, unless we're at a hospital that has inpatient psychiatry, which not most do, and then treat anything medical that comes up. Now, it's very common in situations, especially in the elderly population, where they'll have an infection like a urinary tract infection, and that causes what we call a metabolic encephalopathy, or just a kind of an inflammatory response in the brain, and they can act crazy, they can act like they have schizophrenia even, but then you treat their urinary tract infection and all the symptoms go away. In our screening, we specifically will look for a urinary tract infection to see if there's a medical reason that they could be having altered mental status. Okay, 17-year-old high school student who was sent by a school counselor due to defiance at school, aggressive, fighting with students, arguing with teachers, threatened to kill the principal. All right, so most of the time, this 17-year-old probably isn't going to do anything with this aggression. But what if he does? And what if it gets disregarded and no one does anything about it? And then it becomes one of these news flashes that we turn on and we find out that there's been a school shooting or something like that. So we, of course, we were obligated to be very serious about this. And but it's a common thing, and this was a patient I saw, but it's also a common complaint where the school will send a student over to be evaluated because they've been aggressive at school, and they're fearful that the patient could take this aggression out on a teacher or the principal or other students. And so once again, now this is a 17-year-old, we were able to, I mean, the behavioral health hospitals are pretty strict. They're not 18, they're 17, and so we had to transfer to Dallas, but we did get this patient transferred to Dallas and get an inpatient assessment from a psychiatrist. And we went through the whole medical clearance. Now the whole process, many of you may think that you wait a long time in the emergency department anyway, but for the mental health patients, their length of stays are, you know, sometimes 3, 4, 5 days. If we can't, because we can't release them, but we're waiting on a bed to open up somewhere else and then to get them transported there. So, but yeah, you could just coming in and getting your physical exam, getting the labs done. I can have the labs back in about an hour and a half after they've checked in, or up to 2 hours. So I usually tell them about 2 hours. I'll have those labs back and determine if they're medically cleared or not. But then from that 2-hour point, after they've already been there for 2 hours, then that's where the clock really starts ticking, you know, because we need to get a behavioral health assessment from our local mental health authority, and then they help us determine, and not in all cases, it depends on if they're insured or not, but they help us determine if they need inpatient or not, and then we have to start the process of finding a facility. All right, a 74-year-old male who lives alone, spouse died 4 months ago, quit eating, just wants to die. This is kind of another case like the 89-year-old nursing home patient. So this is a patient who, but it's more acute, because just 4 months ago he lost his spouse, and so this is more so just a case of severe grief where the patient has kind of lost his will to live, which greatly affects your physical health as well. You stop eating and then you get malnourished, and you get so that you're not moving around as much during the day. I've seen patients get blood clots in these situations because they're not moving around, or they get pneumonia because they're not up and moving around. They're not eating and drinking as much, so they don't empty their bladder as much. They get bladder infections. So there are a lot of medical things that we look for, and then if we medically clear them, then we're looking at probably an inpatient psychiatry evaluation, and those can be hard to come by as well, especially in the elderly population. And it can be helpful if you have a local facility or facility nearby that does geri psych, but also a very difficult population to get help for. And the nursing homes, if they are in a nursing home, they are very reluctant to accept them back. And if they're not in a nursing home, I can't really discharge this patient home because they're not safe to be discharged home. But I may have the hospital and case managers tell me, well, they're medically cleared. There's not a medical reason to be admitted. And so then they're sitting in the emergency department waiting for disposition to an inpatient facility. All right, 82-year-old nursing home resident tried to hit a nurse who was attending him. He was cursing, shouting, can't be calmed. When I went into his room, he's tried to swing at me a couple of times. So we had security in there. We had several nurses. I can't medically clear these patients without a blood draw. And so you can imagine you have a patient who's swinging at you, and then you have a needle in your hand and you're trying to draw blood. So it can quickly become a very dangerous situation. This is kind of a placeholder case for this type of a patient that comes in. So we see this very frequently as well. I mentioned before, sometimes it's an infection. Sometimes sometimes a urinary tract infection is what brings about this display of aggression. And sometimes it's dementia and they're scared. And maybe they've recently been moved to the nursing home, but they don't understand where they are and they're confused. They're wondering, hey, where's the surroundings that I'm used to being in? A 34-year-old female went to a party and ate some of the brownies. Now she's feeling anxious. So this is how healthcare has changed, because all the gummies and the edibles, we didn't see them that much 10 years ago. Last couple years especially, we see quite a bit of it. So this patient came in, and she was just really anxious. She had a fast heart rate. It was 130s. I think it was 134, and she didn't feel like she could sit still. She says, I'm just really anxious, and she was starting to have a display of some mental health symptoms as well. She didn't say she was suicidal, but she was very, very anxious. She didn't know what were in the brownies, but we figured, well, let's do a drug screen and check that out. And sure enough, the drug screen was positive for cocaine. And so cocaine is, so some of you have heard of that, huh? Yeah. So when you go to the store and buy brownies, look at the ingredients and make sure cocaine's not one of them. Yeah, cocaine-free brownies. So cocaine is in a class of medications called sympathomimetics, and they can also precipitate a serotonin syndrome. And so you treat it a lot like the methamphetamine overdose, a lot like the patient who had COVID and then started taking the antidepressant medicine. It increases the serotonin levels in the brain, and so I gave this patient some lorazepam or Ativan, and she felt great after that. She felt more normal. Hers wasn't as severe, so I was able to give her a supply of a little bit for home for the next few days while it came out of her system. And she did fine. When you treat these, you have to look at the half-life, and generally it takes 2.5 half-lives of a medication getting out of your system for the symptoms to subside enough that you feel normal. Now, some medications have a half-life of, like the SSRIs, the antidepressant medications, they have half-lives of like 24 to 48 hours. And so if you need 2.5 half-lives of that, you're looking at 2, 3, 4 days of getting that out of your system before you start to feel normal. Cocaine is very, very quick. And then it depends. I don't know if the person they got it from knows how pure it was, and had the MSDS data sheet on it and said, here's the half-life of my product. But so some can be longer than others, but in general, cocaine is very quick, and after a few hours, you'll feel much better. So certainly over 12 to 24 hours, you're going to feel much better after it's out of your system. All right. 36-year-old male, hearing voices, hadn't slept for a few days, mumbles to himself, will not talk to you. Now this is a patient with schizophrenia. And this age group, once you get into your 20s and early 30s, is a lot of times when we diagnose schizophrenia, and they'll usually have some sort of hallucinations, auditory or visual, and it could be complicated too by substance use. And a lot of times they have used substances, and they won't sleep very well. This patient hadn't slept for days, and when I tried to talk to him, he'd just mumble. And he wouldn't really say anything back to me that I could understand, to get any kind of history out of him. So when we did the medical clearance on this patient, everything looked good, and there was nothing that seemed abnormal. The drug screen was negative, and so we felt that we were just looking at schizophrenia and an acute diagnosis of it, and were able to get him into a mental health hospital. I think this might be the last one for the cases. So a 93-year-old female speaking out of her head, mumbles when you ask questions, keeps talking to a relative that died 8 years ago. Well, if you think about a patient with dementia, maybe a urinary tract infection, she's 93, already a little bit confused at baseline, you can explain away a lot of these things. And so many times a 93-year-old, there's not a lot of utility going to a behavioral health hospital. They just need some comfort. They need someone who cares about them, maybe a little bit of a sedative or sedating medication to help them feel better. And then many times, maybe a short hospitalization, or they can be returned to the skilled nursing facility or home if they have someone reliable to take care of them. All right, so sometimes when you go to the ER, the emergency department, the waits are long, and I apologize for that. There's a lot of, some of you can check online and they'll tell you what the estimated wait times are. Some of them you can even check in online and they'll give you an appointment time and you can come and not have to have much of a wait. But I do promise that we try our hardest to be as quick as possible and to address you as soon as we can. Even patients that have minor complaints, we try to have an area where we can get them in and out quickly. So I apologize for the long waits, and we continue to work on that. And I might suggest this: if you feel like you've been there for a while, just scream a little louder, and maybe that'll get you bumped up on the list, so we can get you back sooner. So here's the ER process. I mentioned we talked about this. So you check in and you get triaged, and part of the triage is you're assigned an ESI level. That's an Emergency Severity Index. And I actually trained with the physician who invented the ESI levels, a very brilliant physician, and it works very well, but you take into account their chief complaint, the vital signs, and then your initial assessment and exam, and then you're able to assign a score to these patients, and based on that score, level 1, if you check into the ER and they say you're a level 1, then your heart should be beating pretty fast, and you should be pretty scared, because level 1s are near death, okay? So our heart attack patients that come in, and stroke patients, and severe trauma, gunshot wounds, things like that, they get assigned to level 1. Level 2 is pretty serious, but not as bad. Most of the chest pains get assigned to level 2. And this is a little inside information, so if you want to embellish, you can. Usually if you have abdominal pain or nausea, vomiting, things like that, it's usually level 3. Usually, cough and cold, sore throats are level 4s, and then level 5s are usually like, I need a work note to make it get back to work. So. So according to your ESI level, you get assigned a room, and there's a nursing assessment and a physician assessment, and then from that point, labs are ordered, and then kind of the waiting game comes, because labs can take a couple of hours. If you're getting a CT scan or X-rays, they can take a little bit of time. Ultrasounds, and sometimes it can take up to 3 or 4 hours to get everything back. A good chunk of things will be back in a couple of hours. That's kind of the waiting time, and then those labs are reviewed, and then the decision's made: is this patient medically cleared or not for an inpatient assessment for psychiatry. And then you need that behavioral health assessment, and the local mental health authority will do that and say, yes, we agree, they need an inpatient stay, and then, or depending on insurance, sometimes a direct contact is made with the behavioral health hospital, and then they review all the paperwork, they review the labs that we did, the physical exam. If they have any questions, they call, and we do a doc-to-doc, so the psychiatrist will call me and say, hey, what do you think about this patient? And they'll review everything, and they'll say, well, I'm a little bit worried about the heart rate, it's a little bit high, and we'll say, oh, well, that's the old heart rate, now it's this, we rechecked it, and we just update them. And then if they accept and say, yeah, I think everything is good, the patient looks medically clear, we have a bed, send them on over. And then we wait for an ambulance to be available and transport them. Now, in this process could take 3 or 4 hours at the shortest, or it could take several days at the longest. And you can imagine patients waiting in the emergency department for several days before they're able to, get that disposition that they need. And that's part of the difficulty with the way our healthcare system is set up, and then just psychiatry in general, and being able to get that assessment. It can take a while. These are the labs that we usually do. We usually do a complete blood count, a chemistry, a urinalysis, urine drug screen, thyroids, because sometimes a patient can be hyper or hypothyroid, and that can cause mental symptoms. We usually get drug levels on the drugs that can be very toxic, so acetaminophen level and a salicylate level, get an alcohol level. An EKG, believe it or not, can tell us certain things if they've overdosed on certain drugs, and because it affects the rhythm of the heart. And a pregnancy test, and then since we've had COVID, every facility wants a COVID test. They want to know, is it COVID negative or positive? And during COVID, if we had a patient who was COVID positive with any mental health complaint, the behavioral health hospitals didn't want to receive them because they didn't want to bring COVID into their hospital. So if the patient was COVID positive, they basically would sit until they were out of that quarantine period and then be able to go to the behavioral health hospital. So during COVID, the wait times were really long. I think this is the last slide. So any questions?